I would like to thank the committee for the very kind invitation. And the topic is about hydroxychloroquine and hydroxychloroquine retinopathy and its multimodal imaging. And hydroxychloroquine is a drug that has been recently placed at the forefront as treatment during the COVID pandemic, but its use has been increasing in rheumatic and dermatologic conditions. Hydroxychloroquine retinopathy is a sight-threatening condition with a prevalence estimated at 7.5% and a risk is up to 50% in patients taking this medication for a period longer than 20 years. Risk factors include the dosage, apart from duration, renal disease, tamoxifen use, whereas the presence of macular disease could be a confounding factor in the assessment of its macular effect. The Royal College of Ophthalmologists has established guidelines for the screening of hydroxychloroquine retinopathy, and it includes standard imaging modalities as color photography or cross-sectional spectral domain OCT, both at 6 to 12 months from starting treatment to after 5 years of use, alongside a 10-2 visual field, wide-field autofluorescence encompassing macular and extramacular areas, and also 30-2 visual field if the 10-2 visual field is abnormal, and multifocal electroretinogram. The standard imaging findings include a visual field defect located centrally or paracentrally, along with flattening of the multifocal ERG waveforms in the central area or in the extramacular area. The spectral domain OCT does present with loss of the ellipsoid zone located in similar locations. But it is important, but the importance of early recognition cannot be emphasized enough, despite the presence of a rule of thumb, which is when retinopathy is recognized early, there's mild or limited progression and fovea is not threatened, there is progression. And this progression has been indicated, especially in this recent paper by Emily Chu's group in Retina 2019, in which even in the subtlest form of hydroxychloroquine maculopathy, there is a certain degree of progression after cessation of the medication. This progression in the form of longitudinal changes could present in 4 different stages, including further restriction of the ellipsoid zone or even collapse of the outer nuclear layer. So additional imaging modalities are important for earlier detection of this retinopathy, and I will refer to the unfast swept source OCT, the Hood report, and optical coherence tomography angiography. The unfast swept source OCT does present evidence of loss of the RPE at the level of the outer segment and the retinal pigment epithelium layer in the form of a hyperreflective lesion and a hyperreflective area affected in the inner segment, outer segment. That would apply for more severe cases, but also in more subtle cases. And as you can see in this example of 2 cases, this correlates pretty well with the localization of corresponding visual field defects. This correlation has actually been corroborated by Ann's paper, which shows a direct significant correlation with the mean deviation, pattern standard deviation of visual field index on 30-2 visual field examinations. This modality, the unfast OCT and also the standard imaging, deals with changes located in the outer retina. However, the inner retina is also an interesting and important point and location that could present with some changes. Indeed, as far back as 2010, there was evidence of selective thinning of the macular inner retina, sometimes in the absence of clinical fundus changes. A subsequent paper indicated the presence of bilateral symmetric loss and reduction in the thickness of the ganglion cell layer and inner plexiform layer thickness. This correlation was not established in that paper with actual hydroxychloroquine use. However, some of the patients that had retinopathy or patients that did have high cumulative dose of hydroxychloroquine did demonstrate a thin GCIPL. In our group, we have been using the Hood Glaucoma report, and the Hood Glaucoma report is a report generated from the 3D wide-field OCT at the Triton swept source, and it is a report that does present concurrently any loss at the RNFL, any loss at the GCL projected over 24-2 and 10-2 visual field templates. And after examining 114 patients in our hydroxychloroquine maculopathy screening service, a symmetrical bilateral pattern was noted in 18.3% of those cases. This pattern indicated the profound effect on the thickness of the ganglion cell layer. This pattern was considered inverted in a sense in comparison to the pattern of glaucoma, in which the RNFL was minimally affected in comparison to GCL. Very interestingly, this presentation was not associated with any concurrent macular or optic nerve pathology, and there was no significant difference between cases with or without any of the known risk factors. In addition, a correlation was examined with the unfast OCT cases, and it was shown in this group, in this study, that cases with ganglion cell layer thinning did manifest these changes significantly earlier at 2.8 years, whereas the unfast defect was manifested at an average of 6 years of use. Therefore, the thinning of GCL that was encountered in an important fraction of these patients did develop early on. This year, this paper corroborated these findings, indicating that hydroxychloroquine does seem to cause progressive thinning of inner retinal layers, specifically in the GCL, without any changes observed in the outer retina. I would like to note that this population of 144 eyes did include eyes without retinal toxicity. In this particular study that did have those findings, there was no developed hydroxychloroquine maculopathy, which is indicative of an early finding. Optical coherence tomography and geography is, on the other hand, a modality that has been seminal in medical retina in elucidating many of the signs of vascular retinal pathology, and has a myriad of new signs in the literature. In the case of hydroxychloroquine maculopathy, this paper by Arndt demonstrated the analogous increase of signal voids in the choriocapillaris layer in conjunction with RPE loss at the different stages of hydroxychloroquine maculopathy. And other papers have also noted the choroidal thickness to be thinned, the retinal and the choroidal flow rates to be reduced in eyes that were at high risk for the development of retinopathy, whereas a very recent paper also found a reduction in vessel density, increased foveal vascular zone, and also, yet again, flow voids and reduced foveal choroidal thickness, without having any other sign from the standard imaging used in the assessment of hydroxychloroquine maculopathy, indicating that these vascular changes are actually early events. Therefore, multimodal imaging of hydroxychloroquine maculopathy is of particular clinical importance in the early detection of disease and wide-range screening programs. Modalities include visual field, cross-sectional spectral domain OCT, and autofluorescence, but additional modalities might aid and should aid in the earlier detection of disease, especially due to the development of longitudinal changes. Unfast OCT, OCT angiography, and the use of Hood report, focusing on the comparison of RNFL and GCL thickness, would be or could be valuable. I would like to acknowledge my colleagues at the Royal London Hospital Virtual Hydroxychloroquine Maculopathy Screening Service, and I would like to thank you for your